All right, folks, we're back. I'm your host, BKP, and we are at Circuit World here in Blue Ridge, Georgia. We hope everything's okay. We're trying to adjust some audio here this morning. We got some noise in the background.
It's raining out there.
Well, it's raining out there,
yes. It's rain.
So maybe it's all the rain. Maybe that's what it is.
We're 4 inches
pet rock
up.
was wet.
Pet rock was wet. Dr. William Whaley, Dr. Ray Tidman, and we are at Circuit World here. It's time for Ask the Doc. Is our volume up?
The volume's better.
It's better? Okay. A little bit of hiss, but it's better? Okay, we'll try to see if we can work on that. Dr. Whaley, how are you today?
Fine, and I speak over the hiss.
It's over the hiss.
And this is Nostalgia Jacket today. This is a team issued Atlanta Thrasher jacket that I stumbled across, and how long has that been since they left and went to Winnipeg? Let's see, that'd be 11 years.
Have the Thrashers been gone 11 years now?
We're old, aren't we?
Wow. And he has his tie with Wales.
Yeah, well, that's my man. What's that, Nantucket or something tie, you know. It's all New England
It's
stuff.
family heirloom.
Yeah, right.
Family heirloom.
And Dr. Tidman's wearing his test pattern shirt.
Test pattern, that's right.
Yes. We were checking audio and the
Do y'all
picture
remember
quality.
test patterns? Nobody remembers test
Nobody
patterns.
knows test patterns.
No. I mean, in our audience, I know we have some senior citizens like me, or like I,
Right.
that do watch the program. They would remember test patterns. But
Yes.
I don't think anybody under 50 would know what a test pattern was. Or this guy.
No, I tell you what.
One moment, please.
We need to get to the questions, but you remember the rolling picture? And you had to get up and do the adjustment.
Well, you remember when something went wrong? They had this little guy that had a little sign up like that said, "1 moment, please," and then you might go, like when you're doing this, you might go 5 minutes waiting for Lone Ranger to come back on, just sitting there watching that
Aluminum
guy.
foil on my antennas would do. I didn't have
Do
that
what?
problem. Aluminum foil on my antenna fixed that.
Yeah,
On
college.
the antenna.
Amazing. I mean,
Okay, come on, we're getting too
Now
old
you're
here.
talking
All
about
right.
antennas and stuff. We definitely losing our younger audience.
All right, so here we go. The first question is a really good question, because when it came up, I thought to myself, it's been a really long time since I personally had seen a patient with this disorder, and as I was working on it, I had a patient with this disorder, so don't ask me why. And a friend of mine named David Goldie, who everybody has heard of because 60 Minutes did a program on him, actually came up with the first treatment for this disorder. Okay. My father is 70 years old, and his PCP saw him a few months ago, has followed his blood work for about 4 times, so that must have meant he did one every month. He has referred him to a hematologist who has said he has indolent hairy cell leukemia, and that was sort of like chronic lymphocytic leukemia, and you have discussed this several times before. Dad's white blood cells are 12,000. He feels good, and all of his other labs are normal. His only chronic issue is high blood pressure and cholesterol, and both of them are controlled by meds his PCP monitors. What should we and Dad expect from hairy cell leukemia? And what is it? I've never heard of it. Well, BKP, have you?
No.
I mean, you're pretty well educated, and
Well,
you've been doing this for 3.5 years.
I know. I'm worried this is going to be on the test, and I haven't heard of it.
Yeah, right. I know.
I didn't study for this.
Yeah, well, you're not a doctor, but you play one on TV,
Yes, every
right?
Friday. Every Friday.
All right,
8:15.
go. Put that first one up. This first thing is you think of hairy cells. That's you said guy that stuff all over his head.
Yes.
You like that one, Ray?
Yeah, bald guys don't get this problem.
Yeah. All right, pull that one down. All right, so I'm going to put this next up because hairy cell leukemia is a lymphocyte disorder, and Dad doesn't have any of the symptoms. So he was found by a PCP who was alert to an abnormal blood test when he was seeing him for blood pressure and cholesterol. So give that guy a gold star. Instead of just looking at the cholesterol or writing down his blood pressures, he was checking other stuff. What do you say, Ray? This guy could get to the PCP, get a gold star?
He didn't just go with one number, so he repeatedly checked.
Right, he did it 4 months in a row. Made sure it wasn't the flu or something. All right. Now, you can put that up there and leave it for a minute, but if you look at this real carefully, it says it's got B-cell lymphoproliferative disorder. That sounds like CLL, right? Mm-hmm. Yeah, but this one here has lots more people with a big spleen, fever, fatigue, and this is a very unusual disorder, and it used to have all sorts of names that didn't mean anything. You remember when you couldn't remember the name on your test in medical school? Reticuloendothelioid lymphoma. Lord, you can't even write that down, much less remember it. Pull it down. Interestingly enough, what you have in this disorder, we're going to see a pretty picture, and I made certain that I brought the color picture for you today. Put that next one up. This is why you need a specialized laboratory to make this diagnosis. The machine that counts the blood cells counts these as lymphocytes alone, does not know that there's any difference. So here you've got 4 different pictures of blood cells. That's 4 different disorders. And they all look fairly much the same, don't they? I mean,
yes.
Okay, now pull that next one down. So hairy cells, and this is a picture, both of these are pretty pictures, aren't they? This next one here, you'll notice that these little lymphocytes have these little, the ones on the left there, see that? Mm-hmm. Have all these little projections on there that regular lymphocytes don't have. Pull that down. So the only difference between that under the microscope and a regular chronic lymphocytic leukemia cell is those little bitty projections. And so you have to have a hematopathologist, or you've got to have a really good general lab tech, or he'll just sit right there and count those as lymphocytes when he's doing an eyeball count. But most of our counts, right, 99% of our counts are automated by the machine.
99.9. As a matter of fact, they are, unless the doctor asks for an overread.
That's correct.
So when I would see something like that persistently, I would say have them do another one.
And that's exactly what the PCP did. Pathologist, probably a lab tech if the pathologist sent the bill. But anyway, it gets overread by somebody who physically looks at this, because everything we do now is done by a machine. Unbelievable, isn't it? Yeah. All right. Got to have an algorithm for old BKP. Hey, BKP, there's your algorithm. So, this guy falls into this category, asymptomatic, no symptoms, right? It said didn't have a big spleen, he's got blood pressure. Over here where you've got all this business with the spleen and the fever and all that stuff, pull that thing down now, because I want to tell my story. David Goldie was a famous guy. He was the chairman of the Department of Hematology at UCLA. And he took the spleen of a patient who had hairy cell leukemia, and he was culturing the lymphocytes and the other cells in there, and he discovered the I guess you call it a hormone called granulocyte colony stimulating factor, and he isolated that factor, and that factor was the precursor of GCSF and all growth factors. It was before the Lance Armstrong erythropoietin and all that. The potential value of that was said to be $5 billion. Well, it turned out that this spleen had been removed from a guy with hairy cell leukemia, and somehow or other the guy that had the spleen discovered that it was his cell that had been cultured that came up with GCSF, and he sued Dave Goldie for $5 billion. Now, Dave was the chairman of the department at UCLA, and they did not have indemnity coverage, and Dave Goldie personally had to fight this lawsuit all the way to the U.S. Supreme Court. And the crucial matter of it is this: if you have your appendix removed and they take it to the lab and they look at it, have you given up authorship and ownership of your appendix? Or the biological products made from that appendix if they decide to do something. So at the end of the day, David Goldie spent about $500,000 of his own money defending this lawsuit. He won at the U.S. Supreme Court. 60 Minutes did a program on it, and the issue was that if you have gone to the toilet and done your duty and you've washed it down the toilet, you don't own it anymore. And so Dave Goldie won and resigned from UCLA and went to be the head of the Memorial Sloan Kettering. Dave Goldie was the guy that discovered the use of interferon to treat hairy cell leukemia, and that was the first treatment for it. So Dave was a good friend of mine. He ended up having a bad outcome for another reason. So anyway, this is really a disease that you don't treat unless you get the symptoms. And it's got nothing to do then with the number of white cells, generally in chronic lymphocytic leukemia, right? It's the number of white cells, or did you get anemic or something. But these guys get fever and a big spleen and stuff, they've got to be treated. Throw this big next chart up, because it's all nice and pretty. But it's got 8 different categories of response. And this is one of those diseases where you're trying to treat the guy and get the symptoms to go away, get his spleen to get smaller, let him go back and play golf. It responds well to treatment, and I would say, you can pull that down now. They want to know what to expect. I think your father can expect that he is going to remain asymptomatic. Didn't they say he was 70 years old? A 70-year-old man today that has high blood pressure and cholesterol, that is well controlled and no other symptoms, how long is he going to live, Ray?
He's 70 and no other symptom. He's going to live to the age of his father or his mother. So.
Or probably a little beyond. So, I mean, you ought to get a few more years out of it. Actually, I think if you predict that age, back when Social Security started, the average man died at 57, the average woman died at 62.
Weren't many payouts on that.
Yeah, right. Now it's at 72 and 77 or something. But I think the prediction of here, with just those 2 risk factors, would get him to 79, 80, or 81. So I think your dad's going to have a good time, and let him keep seeing the PCP.
All right, folks, we want to thank Georgia Cancer Specialists, affiliated with Northside Hospital Cancer Center, for these segments. And so anything you want to add to that?
Well, I mean, I would just say if I had to have leukemia, I'd want, for my grandchildren's sake, I'd want to have hairy cell leukemia, because that's a pretty cool sounding leukemia.
So when they take their history, they say
Grandpa had hairy cell leukemia.
Yeah, that's right. But anyway, I think this points out the fact that
that's what you bring to
that's what I bring to
I think the guy got really good care of his PCP myself. That's what I think. All right, this is a little bit more. This is a little bit easier to do, and it's one that we've done so many times before that I think it can be relatively quick, but it's big time important. All right, my husband is 80 years old. So this guy's 10 years older. So he had a CAT scan in the ER 6 weeks ago when he developed a cough with COVID. Everybody that's got COVID's got a cough, haven't they? Apparently he's fine china and had not been immunized. He got over COVID, but had a 2-inch mass in his lung, which has been biopsied. And a surgeon wants to remove the cancer, which was diagnosed by needle biopsy as squamous cell cancer. So he didn't have any symptoms from the cancer. He wouldn't have this diagnosis if he'd not had COVID. We say here frequently, a guy fell off his lawnmower and hurt his ribs, and he went into the ER to get an x-ray to see did he have a broken rib, and they find a small tumor of this size. These can be cured, can't they? This is not a big tumor, and it was diagnosed because of it. All right. He had a PET scan and a brain MRI. Now, those would have been done to see if he was a surgical candidate, and the only abnormality is the lung.
So, Bill, just to emphasize, that means that they can remove this tumor and get the whole thing, and they don't have to worry about Mets.
That's right. Nothing's in the brain, and that's where the MRI of the brain goes. That's a sanctuary. And so, all right. So it was suggested he see an oncologist to see if he has any other options. Now she gives you the rest of the story. He has atrial fibrillation on Eliquis, high blood pressure, stents in his heart and legs, and COPD. He has diabetes on pills and a long-acting shot. Are there options? And if so, what are they? Now, you got a handful of 6 comorbidities here.
Yeah.
And we don't know how good his heart is, do we?
Well, we don't. We know that he's got a propensity to have heart attacks. Maybe they're being aggressively treated. There are medicines that can stop the progression of atherosclerotic heart disease. We don't know his pulmonary function test. We don't know how, whether he's on oxygen at night or how hard it is for him to breathe.
No, and we don't know how long he smoked because he didn't mention it, but I guarantee you the guy smoked. But anyway, we do know he's got stents in his heart and his legs, so that's vulnerable. All right, let's go to this next one here because this is this one's fun. All right, so squamous cell cancer, put up that first one. Remember, almost all the lung cancers we've talked about recently have been the adenocarcinomas, many of them in non-smokers. We've talked about small cell lung cancer. Well, squamous cell cancer, Ray and I both are great examples because we've all had all this sun-damaged skin on top of our head. You remember that? Say, look, they go freeze that off, but one of these will turn into a squamous cell skin cancer one of these days because this was irritated by bald head and sun. Mm-hmm. Now, you could pull that thing down if you want. This was, I guarantee you, a smoker whose tracheobronchial tree was irritated by the tobacco, and this squamous cell lung cancer has a little bit different biology than the adenocarcinoma. So put that one up a minute. Here in this you got two different lung cancers. One of them over here is greater than 3 or 4 centimeters. That's a bigger one. And this one over here on this side is 2 centimeters or less. That's what he had. All right, pull that one down. What's that BKP?
Algorithm.
Algorithm for BKP.
Yeah, that's the algorithm.
Put the algorithm up for BKP. Here it says, stage 1 or 2. Is he a surgical candidate? Well, I was going to say probably not. If he is, you take the darn thing out. So if it was you, we'd take it out. Now, Ray and I both got some age on us. But what the other options are, SBRT. Now, you've heard that several times. That's that gamma knife we use for the brain tumor when they focus that radiation right on the spot. And the survival with that versus the survival with surgery is precisely the same for the first 5 years or so. And I'm not so sure this guy's got a lot longer than 5 years. So pull that down.
Well, not only that, Bill, I mean, if he's got a tumor of 2 centimeters, he's got a big tumor, and like when you have something cut off your skin, you don't just take that little thing off, you got to take tissue around it. So by the time they get that thing out of his lung, he may not have enough lung left to live on him.
You got it, Daddy. So that's exactly what this next picture shows. Yeah. Put that up, that pretty picture there. This is the stereotactic image that they would use to radiate him, and that tumor is right there in the middle, and you see that little box around the outside?
Yes.
That's Ray's margin.
He's got to go right outside.
But you can make the margin a lot tighter with the radiation than you can with the surgery. Because with the surgery, you got to go in there and cut. You can pull that down a minute. You got to cut a blood vessel that feeds an area of the lung. So you can't take out just a tiny piece like that. You got to take out that wedge. So you would be removing more lung with surgery than you are going to kill with the radiation. So throw up the next one. This is exactly this is not that patient, but this is exactly the same case. There is a 2.5 centimeter tumor. This patient got stereotactic radiation. This is a picture 2 years later, and this little streaks you see there are the scarring down of the lung from the radiation, and there is no recurrence. So this guy has not lost much lung function in those little scars there, and his cancer's gone. And I would imagine that he's in the same kind of shape he was. You can pull that down. Same kind of shape he was before. And BKP, what's that?
Survival chart.
Yes, survival chart. So his stage of cancer is way up here at the top. That's the best survival you can get. You're out here at 5 years. Now remember, this guy's 80. This is all-cause mortality. So at 80, at least 55% of these patients that are treated this way are alive without disease, or alive, excuse me. They may still have some active disease. So that's the option that your dad has. A medical oncologist is where he ought to go next. That medical oncologist will weigh with him the options, and your dad, will make the decision. When in doubt, cut it out. I'm scared to death, and I'm willing to take the risk, or I don't want anybody to chop open my chest if I can get just as good a survival with something that doesn't hurt and I don't have any stitches, and I want to go that direction. So you can't make that decision for your dad. He's got to make it for himself. Is that good? Finish?
Well, that's good, and it's a hell of a way to lose weight. But aside from that,
You had to throw that in.
let's digress for a second. In the 80s, the tobacco industry was still telling people that cigarettes did not cause cancer.
Right.
Now, use of cigarettes has gone way, way down. Way down. A lot of people quit. Most people want to try to quit, but young people are still picking them up. Unbelievable. Why? Because that didn't change. The cancer from cigarettes doesn't change. The other point I want to make here is that on TV, on the media, there were regular broadcasts saying cigarettes don't cause cancer. Today, on TV, on the media, there are all kinds of people making statements that are lies. And how do you figure it out? You got to pay attention and ask people you know that you trust.
Interestingly enough, I read an article yesterday. Excuse me, I read the abstract of an article yesterday that was sent by Steve Marlowe to me. That's our expert. That the number of physicians who are on the social media, mostly, I don't know, I couldn't find YouTube if I don't know, our programs are on YouTube. On YouTube, that have opinions about all sorts of stuff, like nutrition and hyperthermia, curing tuberculosis and stuff. And people who watch that say, well, why would this doctor, he went to Harvard, or why would this doctor, he's got an MD and a PhD, tout this stuff if all the scientific community and all the evidence says it's not true? Well, first of all, they thought the earth was flat until Christopher Columbus proved it wasn't. The guy's got the right to advance his opinion, but when 99.9% of the world says that opinion's wrong, you got to be real careful about taking every one of those and believing them. And so I agree with Ray. I think you need to sit down with your own doctor, or go take a course at Georgia Tech at night or something, and learn the evidence yourself.
Well, I understand what you're saying, because there was a time when, it was years later before there was an admission of cigarettes cause cancer. So. Yeah. If you take things today and you think about that as an example,
we're going to look back and say there are people that were just flat out lying.
Right. Folks, before we move on to our news of the week, our medical news of the week, and our discussion, we want to thank Georgia Cancer Specialists affiliated with Northside Hospital Cancer Center. So, what direction you want to go in? What's the news of the week that you want to...
I hate to keep telling you, but the news of the week remains we are in the midst of a COVID epidemic, and I saw a statistic yesterday that 1 in 500 Americans have died of the COVID disease since the epidemic began. That's a big number, 1 out of every 500. And so I put a pin to it, and blinking, that's about that. If you believe the numbers, that's about right. Georgia's number is 1 in 400. This is the COVID epidemic. Hospitalizations, death rate, and ICU admissions going all the way back to the beginning of this epidemic in April of 2020, and the numbers today are higher than they were at both of the prior peaks. And there was a well-publicized guy who died a day or two ago, and his obituary says he was turned down by 42 hospital ICUs because they were full.
Because of the what?
They were full.
Oh.
And we know that yesterday a hospital in some place or other had to close their OB service because they don't have any nurses, and the hospital's full. That we talked last week about a patient who was in our local emergency room on a gurney for 6 days looking for a place to go with an obstructed carotid artery. So people who are needing to have angioplasty or needing to have other kinds of procedures can't get in the hospital. And I sent Ray a couple of things from several of the big hospital systems that said you can do in the outpatient department colonoscopy, EGDs, and various procedures if you are absolutely convinced the patient will not need to be admitted and you can go home after the procedure is done. So you can get your colonoscopy, you can get your mammogram and stuff, but if the procedure they're talking about doing, let's say it might be a laparoscopic gallbladder, most of those go home. They will restrict that procedure because a few of them, 10% or something, have to spend the night. So there really aren't any hospital beds available right now for something other than COVID. Is that right, Ray?
Well, it's right,
Or
but
close to right.
I keep trying to temper our message. You know, COVID is the big word. It gets all the attention. It gets all the news. But leave that up for a second, Bill. That graph. When you look at that graph, and I'm not sure if you showed it on the screen or not, but it shows a series of 3 spikes. And between number 2 and number 3, a vaccine has come out. And during all of that, we've had people saying, well, you got to social distance, and you got to wear masks, and you got to do this, and you got to do that. Well, the spike hasn't changed. Spiking has not changed. We're doing the same things now that we did before, and it's not changed, okay? So my point is that we're still not there yet on what it's going to take to beat this thing. And a lot of work has to be done by physicians. And anybody that runs around telling you, well, if you just wear a mask, and if you just social distance, and if you just get your vaccine, you're fine. No, you're not fine. You're not fine. And there are a lot of other things Bill and I mentioned all along that you need to be paying attention to, including whether you're fine China or not, and how high a risk you are, and then get good advice from somebody you trust. The other big point of this is that for young people, COVID is not a big issue. It's not.
Still isn't.
Still isn't, and it probably is never going to be. But I just heard this interesting number yesterday that the chances of a child being shot in a homicide is higher than a child dying of COVID in this country. Now, let that soak in for a minute. Okay.
More children have been shot in Chicago thus far this year, okay, and that's just Chicago, than have died.
COVID. And you can extrapolate that all across the country when you do the averages. So, you know, we try to take a big problem and focus it down and say, well, who is it a big problem for, and what do they need to do? Because you cannot in life be constantly surveilling every possible risk at all moments all the time. So as humans, we look at what are we at risk for, we identify those things, and we deal with it. So I'm constantly trying to push back and say, every time somebody says COVID, like, no, okay, let's get on with our lives. Let those people who are really high risk for COVID deal with that. And oh, by the way, with their own free, independent choice, nobody gets to make decisions for other human beings. And there is another big wave going on of saying, well, I'm going to take care of you, and this is what you're going to have to do. And that's repulsive and should be pushed back at every moment.
Yes, sir.
I want you to read that number.
12.9.
Remember, it was 20 2 weeks ago. It was 15.5 last week. So that number is doing what?
Coming down.
Okay, what was it the week before the 4th of July? 1%.
Right, 1%.
So this thing began the week of the 4th of July. This is what, 3 months, 2 months, August, September, it really, almost 3 months later. It peaked out here about 10 days or 2 weeks ago, because with these positive test results, the 2 week ago test results when it was 20, those are the people in the hospital now. Mm-hmm. So this number's fallen. I expect the hospitals to start opening up in the next 2 to 4 weeks. I do not agree with shutting down a ball game, a kids game. I do not believe that there is any body who should be telling schools that your kids have to be immunized to attend the school, that they have to be immunized to participate in sports. And I think Connecticut or somebody came out in the last day or two that if you're on an athletic team, you're going to have to be immunized if you're 12 or older. And isn't 12 to 15 still experimental?
Yeah.
I think the Pfizer vaccine was, quote, approved for 16 and over. But, I mean, I would tell parents of adolescents, there's some that you want to get shot, like my grandson, who's the field goal kicker. He's got to kick this year. He's going to college next year, and he's got to play. But the kid that's on the bench, I mean, he doesn't have to take the shot. I mean, and I was asked yesterday by a 48-year-old woman who just is being remarried, should she take the injection? She has 2 risk factors. She's diabetic and she's obese. And I said, do you have any chance that you might want to have another child with this new marriage? She said, I haven't decided yet. I said, don't take the shot.
Yeah.
I would not recommend that any woman of childbearing age, I mean, absent some, that she's got CLL or something, to take the shot.
No, there's no reason to take that risk whatsoever. And I keep trying to nuance this. We are a free will society, culture, and people need to be informed and execute on their free will. And to me, the harder you push on the button of you're going to have to do this, we're going to make you do this, as is going on around this country right now. There are people who are losing their job because they won't get the shot. Well, that's going to make less people get the shot. That's going to make more people angry. So if you think you're going to get more shots out there by forcing some people to do it, I think that's just ignorant. And it is, Bill mentioned that babies are going to come out whether you have COVID or not. You got a hospital in New York that was almost shut down, couldn't do babies because the nurses said, well, hell, I'm not doing this. And they didn't have staff to do babies. So, yeah, this whole authoritarian thing of telling people what they are going to do, it just needs to be smacked down hard.
Well, the National Guard will go in there and deliver the baby.
Yeah, that's right.
Well, let me say this. All right, now I want to close with this, but I don't want to get this out this week. I try to take this and look at it with common sense.
Yeah, common sense.
So we have a vaccine. We have a vaccine that Pfizer started using, Moderna and Johnson & Johnson, under emergency authorization. And then the FDA said to Pfizer, okay, we're going to approve your vaccine. Now, these are all studies that are going on, and I don't know how it works, but the FDA said, we're going to approve your vaccine. And through all this study and research and testing on people, somehow they weren't able to determine if it was going to have a 6-month effective rate
or lifetime or
or
what?
lifetime. Somehow that didn't get.
That's because
figured
time
out.
you don't know till the
Wait a
time
minute,
goes
wait a
on.
minute, wait a minute,
All
wait a minute. Now, so I'm putting all this together because I don't want to call it an argument. I'm hearing vaccinate, don't vaccinate. And then, so you have this vaccine that you don't have figured out, do we need it in 6 months? Are we going to need it every 6 months? But at the same time, we have enough research to know that expecting mothers that took the vaccine, mothers that had the vaccine during the pregnancy, kids that are born to women with the vaccine. I'm just saying all of this, and we don't know if we need a booster from this thing.
Now,
I have to tell you, you as physicians can't get upset with us out here for saying,
No.
whoa, wait a minute, everything's a little confusing to me.
Well, the FDA is deciding today whether they will even weigh in on the booster shots.
Yeah, I think the advisory councils that have weighed in on it, and Steve thinks that they're too cautious. Steve believes you should get a booster. Let's just say that. Our consultant says get a booster after 8 months. I don't see any good expert panel yet that has come up with any convincing data that would tell me that we know enough now to suggest a booster. Now, I would also say that there's enough information that people who really want to have a booster at 8 months, let them go get the booster.
Let them have it. Yeah.
Let them have the booster. But I cannot tell them. I can't tell them that the data proves that booster is necessary or is going to necessarily be any better than what you have.
Cut right back to your point. Your point is, what should I do?
Wait, I want to throw one more point in. So I'm going to have to tell you that to me, there's still a lot of doors open here that the medical world has not closed for my comfort level. Now you're telling me, the public I'm watching out there, that by October, you'll be able to tell me that kids from 5 to 12 are ready to take it, and not long after that, infants to 5.
No, here's what I'm telling you. Okay, here's what I'm telling you, is that you have a world that's flipped on its head now, where people that are far away from us, that have a great opinion, that live in ivory towers, that don't touch patients, are telling you what you should do. And I'm saying, and Bill is saying, ask those people that give you advice, personal advice. You study yourself, you study your heart, and you ask your experts, and then you decide what you are going to do and tell everybody else to go to hell.
All right.
Is he allowed to say that on the?
He can say that. He can say that because here's the thing, and we're going to close with this. And sometimes we get a little too personal with our audience here, but we love our audience, and we just talk about things. Now, since COVID has started, I have gone into every burning building out there, and that's the only way I know how to put it. All right. I've gone into every burning building I could go in. And sorry if this upsets you out there, without a mask, okay? I mean, I know I'm living dangerous, okay?
Dr. F's going to send somebody after you.
All right.
He's going to lock you
now,
up.
I have run through airports, and this is when it started in March. I went through airports.
You can't do that now. They'll hit you with a baseball bat.
Right, now I'll get a fine. I went on flights, which you guys know that all too well. At that time, they hadn't told us to put a mask on yet. And again, I have run into every burning building I can. Now,
you're a series of one. You're an anecdote.
I get that. But now I feel fine. And for those out there, which because these two doctors have brought it up on many occasions, maybe I could lose a couple pounds. I could be if I have COVID, I could be in a bad
high risk group. Yeah.
High risk group. I get that. But right now, I'm not understanding why somebody needs to rush me to get a vaccine. I don't understand that right now. I don't understand why
that's your decision to make.
But the government wants to say...
It's your decision to make.
But
your chances, if you got COVID and are obese and are over 50, are...
pretty low.
A couple of percent.
Are you breaking it to me right
now? No, but I mean, you've proven it. You've proven it. But in the meantime, you could be one of those rare people that's never going to get it.
But if you got it,
or I may have had it and don't know it.
No, you didn't. You haven't. If you got it, you're going to be sick. You might be home for 10 days or 2 weeks, hurt like the devil, and you've had some bad flu in the past. There was somebody, Jeff Bridges or somebody in today's news said, COVID beats cancer chemotherapy 10 to 1. It's much worse. And he had some kind of cancer.
You're looking at somebody who had it, and if I can say so, it's an ass whooping.
Well, I don't know. I mean, I'm
and
not.
You were immunized.
Yeah, I was immunized.
And I'm not an anti-vaxxer, and I don't want to go there. I'm not, folks out there. I'm not. I had all my immunizations, went to school, all that. We could discuss it. So I'm not an anti-vaxxer, but this one here,
you're not convinced.
I'm not convinced, and I have never come on and said don't.
No, you should
never come out of my mouth.
No, you should not. Don't.
It's your personal opinion. It's your life. Do what you want. And if you get it, fine. I know people that have the vaccine, and there are 2 guys here. I'm fine with that. I'm just, it's like you said, you got a hospital in New York this past week where 6 or 7 nurses said, I'm leaving, okay? And as you are both affiliated with hospitals, I have some family affiliated with hospitals in other parts of the country, and they have people leaving.
Well, as of October 1st, you will not be on the Emory staff unless you have had your vaccinations, and I've had mine. And many physicians are of the opinion that it's much more important for them to be treating their patients and be on the hospital staff, and they are taking the vaccine now, even though they've gone through all of this last, 10 months or something without taking it, because they didn't want to, but now I've got to go treat my patients. I need to stay on the staff of Emory, Wellstar. They're all say you got to be vaccinated. So the physicians
but
that I know are taking
everybody.
it. No, it's just doctors.
In so many industries, we can't afford. It's just
I took plague vaccine before I went to Vietnam. You want something to make you sick now, you take the plague vaccine.
We have truck drivers. We'll just use that. We have shortages of people to drive trucks, to deliver food to these restaurants, and so forth. And what you want to do now is say, if you're not vaccinated, you can't drive that truck.
Now, that doesn't make any sense, does it?
But it's
Well,
closing.
not only does it not make sense, our country and our lives are about freedom of choice. And we need to get back to our lives. And that's the final statement I have to make on it.
Yep.
Final statement?
Guys in the blue room are chomping at the bit. Let's give it to them.
There you go. We got to. You got to get to work. You work today? Are you off on Friday?
I don't know. I'll go ask.
You got to go see?
Yeah.
Okay. He's going to check in. All right. We'll be right back, folks, with the All-Star panel.
Got to ask the boss, right?
That's right.